Good morning, everyone. Thanks for joining us for Grand Rounds, both this year and today. So we're really excited to kick off the series today. I'm the director for Grand Rounds, Dr. Steve Foost, and really excited to introduce our first speaker this year, Dr. Dave Tanaka, who will be talking to us about BPH. Dr. Tanaka did his undergrad at the University of Washington Medical School at University of Washington as well, and then did residency here at the University of Colorado. Today, he'll be talking to us about assessing BPH treatment with both medications and procedures. As we go, please, if you have questions, raise your hand. I can bring you the microphone if you're here in person. If you're attending virtually through Zoom, type it into the chat, and I can ask our speaker. And the last thing I'll say is I'm just generally really excited for Dave to talk to us today. When I joined faculty a few years ago, one of the grand rounds I attended was him talking about stable chest pain, and he was so phenomenal that I actually thought he was a cardiologist. And so today, I'm sure I'll think he's also a urologist. And so with that, I'll turn it over to him.
Thanks, Steve. Well, today I'd like to talk about benign prostatic hypertrophy. Um, I have no disclosures. So, learning objectives. To efficiently and accurately evaluate BPH and lower urinary tract symptoms or LUTS, appropriately utilize medical therapy for BPH and LUTS, and understand and guide patients when surgical therapy is necessary. So we'll talk a little bit about some of the different surgeries. We won't go over all of them. There's really too many, but we'll hit a few highlights. Just a few quick notes. This is the anatomy. The prostate sits right below the bladder. The urethra goes right through the middle of the prostate. The sphincter is right inside the prostate. And so where do most prostate cancers develop? You guys don't have the audience thing, but is it the anterior, central, transition, or peripheral? And the answer actually is it's in the periphery. So it's right around the outside of the prostate. And then where does BPH initially develop? Peripheral, transition, central, or anterior? And so this is actually in the transition zone. So it's right around the periurethral zone. And so what happens? So BPH arises because the loss of homeostasis between prostatic cellular proliferation and apoptosis or cell death. This imbalance favors cellular proliferation without intervention. So we can actually intervene and slow this down. The results are increased numbers of prostatics, periurethral epithelial and stromal cells, which can be seen histopathologically. So the reason for this is testosterone is converted to dihydrotestosterone by the 5-alpha reductase 2 enzymes in the prostatic stromal cells, and accounts for 90% of the total intraprostatic androgen. So the dihydrotestosterone is extremely important in terms of this cellular proliferation. So it directly influences these adjacent stromal and adjacent cells, which affects cellular proliferation and decreases apoptosis. So we break down the symptoms or the lower urinary tract symptoms into two different types. Storage, this is frequency, nocturia, and urgency and voiding. Weak or intermittent stream, straining to void, hesitancy, prolonged micturition, incomplete emptying. And the way that we try to quantify this is using this standardized questionnaire. So it's called the International Prostate Symptom Score. It was initially the American Urologic Association score, but they changed the name. It's the same thing. So basically, it's over the past month, and then they ask a number of different questions. So the first question is incomplete emptying. So Do you have incomplete emptying? Not at all. Less than 1 in 5, less than one half, about a half, more than half, or almost always. So going from 0 to 5. And that's the same scale for all of them. And so it's incomplete emptying frequency. That's how often do you have to urinate within 2 hours of emptying your bladder? Uh, Intermittency, how often do you stop and go when you urinate? Urgency, how often do you have difficulty restraining or having to go to the bathroom? Weak stream, how often do you have a weak stream? Straining, how often do you have to strain or push to urinate? And then sleeping, how often? And this is basically 0 times a night up to 5 or more. So the maximum score is 35. A normal score is about 1 to 7, moderate 8 to 19, and 20 to 35 is severe. And the last question is if you had this degree of urinary difficulty for the rest of your life, how satisfied would you be? You'd be delighted, 0, or terrible. So it's a validated instrument. It does give us a way to sort of quantify how significant these problems are. And if you give it to your patient beforehand, they can answer. So the differential of the lower urinary tract symptoms, so quite a few. Atonic or decompensated bladder, bladder neck strictures, bladder or prostate cancer, bladder overactivity, Cauda equina syndrome or neurogenic bladder can present with acute retention. High pressure chronic retention, so patients that are unable to empty their bladder can develop chronic retention, which can cause renal failure. Neurogenic bladder can be secondary to Parkinson's, multiple sclerosis, diabetes, etc. Prostatitis, renal failure, sexually transmitted diseases, urethral strictures, urinary retention, urinary tract infections, and urinary tract stones. So quite a few things. Fortunately, it's not that difficult to rule most of these out. Non-urologic conditions, diuretic use increases symptoms. We use these for heart failure and hypertension. Neurologic problems such as Parkinson's, stroke, Cauda equina, multiple sclerosis, and various spinal cord disorders can affect the complex reflexes used to store and void. Poorly controlled diabetes causes polyuria, but it also which causes the osmotic diuresis, but it also causes detrusor neuropathy, resulting in decreased bladder sensation, reduced contractility, and incomplete emptying. And diabetes insipidus can cause all these same symptoms. Fortunately, it's pretty rare. So red flag symptoms, these are things we want to not miss. Prostate cancer, spinal disorders such as equina, chronic high pressure retention, which can lead to silent renal failure due to reflux, urinary tract infections, and acute and chronic prostatitis. So how is BPH diagnosed? It's diagnosed like we do almost everything. It starts with a history. So when did the symptoms start? What symptoms do you have? How have they progressed? Is there a history of urinary tract infections? What medications do you take, both prescription and over the counter? Over the counter is really important. I had a gentleman who was in his 50s who went on a business trip to Chicago, had a cold, got some cold medicine, took a couple Dimetapp tablets. It's a combination decongestant antihistamine. Called me from Stapleton. This was a long time ago when Stapleton was still there. He said, "You got to help me. I haven't been able to urinate for 2 days." Oh my God. So I directed him to the emergency room. He had more than 2 liters in his bladder, and it was from 4 Dimetapp tablets. So the over-the-counter medicines are very important. How much liquid does he drink? Does he consume things that might irritate the bladder, caffeine and alcohol, and general medical conditions? The exam is pretty straightforward. There's a brief general exam and a rectal exam. When there's a change in symptoms, I think that really is an indication for us to do this exam, mainly to see if there's a change in the prostate. We want to rule out that there's nothing else going on. We can't just assume that it's always benign. So the other thing that allows us to do is sort of just get a general gestalt of the prostate size, and we can maybe do a little bit better. This is one way that we can sort of guesstimate the size of the prostate. So a normal prostate is a little bit more than 10 grams, usually between 10 and 20. So I don't think I've ever felt a 10-gram prostate. It's been a very long time since I felt a 20-gram prostate. Most of them are larger. So the number of finger breaths sort of equals the number of grams, or you can also just gestalt it. A is about a 20-gram prostate. B is a 30 gram, C is 40, D is 50, E is 60, and F, I don't think I've felt one that big, but that's probably more than 100. So medical tests is actually pretty straightforward. A urinalysis and a basic metabolic panel to check the creatinine. PSA and post-voidal residual are sort of extra tests, not necessary in everybody. But this is one case where a PSA may give us some additional information other than screening for prostate cancer, because a PSA is somewhat predictive of prostate volume. So a benign prostate of about 35 cc's typically generates about a PSA of 1.5 nanograms per mil. So if you do check a PSA and it's greater than 1.5, then you can assume that it's probably greater than a 35-gram prostate. PSA testing is recommended where cancer is suspected. So if you have an abnormal exam, I would check the PSA. So if you feel a nodule, there's asymmetry, or if you unfortunately have a gentleman that comes in that you suspect metastatic disease. If you have a previous baseline, this also does give you an idea of how much the prostate has enlarged. That can be important when we're thinking about medications. PSA testing is not a routine test, but is recommended before starting 5-alpha reductase inhibitor therapy or performing surgery to avoid missing a possible prostatic malignancy. So how is BPH treated? Lifestyle, medications. There's new minimally invasive procedures that we'll talk about, and then more traditional surgeries. Lifestyle changes. I think we should probably recommend these things. I think most men that have these symptoms have already done this. So I'm not sure that, if we just do this, that they'll be perfectly happy and say, that's great. But they can reduce the amount of liquids, particularly before going out in public or before periods of sleep, avoiding or reducing intake of caffeinated beverages and alcohol, avoiding monitoring use of medications, especially those over-the-counter medicines, the decongestants, antihistamines, but also antidepressants and diuretics, training the bladder to hold more urine for longer periods, exercising pelvic floor muscles, and preventing and treating constipation. Again, probably not going to change that much, but reasonable to ask. Medicines. So these are the medicines that we use for BPH: alpha blockers, phosphodiesterase 5 inhibitors, 5-alpha reductase inhibitors, and combination medicines where we use these and plus others. So the most common medicines that we use are the alpha blockers. These medicines relax the smooth muscle, the prostate and the bladder neck, that sphincter, and allow improved urine flow and decreased bladder blockage. There's a number of them available: terazosin, doxazosin, tamsulosin, alphazocin, and silodosin. 5-alpha reductase inhibitors. So these medicines block the production of the dihydrotestosterone, which is key in terms of the prostatic hypertrophy. There's 2 of them available, finasteride and dutasteride. So they prevent the progression of prostate growth and actually shrink the prostate in some men. I would say actually they shrink it in almost all men. Finasteride and dutasteride act more slowly than alpha blockers and are useful only in moderately enlarged prostates. So for a man with a small prostate, these are not going to be effective medicines. And I think if we use these, we need to counsel our patients because they'll say that they're not effective unless we tell them how they work. Phosphodiesterase 5 inhibitors. So tadalafil is the only one that's FDA approved for this. It belongs to a class of medications that relax the lower urinary tract symptoms by relaxing smooth muscles in the lower urinary tract. So these do improve the IPSS score and increased maximum urinary flow, but not as much as the other medicines. So you have a 60-year-old man with bothersome nocturia and slowed stream. He has a history of hypertension. He's on lisinopril. He requests medicine for his symptoms. His prostate's 40 grams. His UA is normal. What would you recommend? Finasteride because of the enlarged prostate. Tamsulosin, least likely to cause orthostasis. Tadalafil, fewest side effects. Saw palmetto because it's natural. Again, you don't have your audience response, but so there's very little data on the natural medicines in terms of improving IPSS score and urinary flow. So it is natural, probably is pretty safe, but there's no really good solid evidence that it really does help. The tadalafil does have the fewest side effects, but probably is the least effective of those medicines in terms of symptoms. The finasteride does improve symptoms, but it will take about 3 to 6 months before it's going to actually do anything. So I think the correct answer here would be to start him on the tamsulosin. It is ural specific, so it does cause less orthostasis, so that part is true. And it really does improve urinary flow and usually symptoms. But so your patient returns. He's on the tamsulosin. He has excellent improvement in urine flow and decreased nocturia, but he complains of sexual dysfunction. Now, what do you recommend? Change the tamsulosin to silodosin. Change the tamsulosin to alphazocin. Change the tamsulosin to doxazosin, or add tadalafil to the tamsulosin. Okay, so the least correct answer would be change the tamsulosin to the silodosin. The silodosin and the tamsulosin are urospecific, and they do cause less orthostasis, but those two cause the most sexual side effects. The alphazocin and the doxazosin are not urospecific, so they cause fewer sexual side effects. And so we'll talk about those just in a second. Adding tadalafil to the tamsulosin would be correct if the sexual side effect that he had is erectile dysfunction. But the sexual side effect most often caused by alpha blockers is actually retrograde ejaculation or anejaculation. So it probably won't help. So probably the correct answer would be the alphazocin or doxazosin. They're fairly equal in terms of benefits, so it'd be sort of just up to you to choose. So there are differences in the alpha blockers, and so they seem to all improve the IPSS scores about the same, about 4 to 8 points. Most they're pretty close to 8, and they increase urine flow 16 to 25%. They all have pretty long half-lives, 10 to 22 hours. The most common side effect is orthostasis, even for the urospecific. So the tamsulosin and silodosin still cause orthostasis, but it is decreased. The alphazocin and the doxazosin are much less likely to cause the sexual side effects, but they do have an increased risk of the orthostasis. The doxazosin probably is a little bit worse than the alphazocin. There is a doxazosin gastrointestinal therapeutic system that changes the way you absorb it. This is only available in 4 and 8 milligram tablets, and it's dosed in the morning, not in the evening. And when compared to tamsulosin, it has better efficacy and fewer side effects, but it's fairly expensive. So if your patient has actually really good insurance and they're concerned about sexual side effects, that might be a good option. Patients should be warned to discuss their medicine with ophthalmologists prior to cataract surgery because of the Fopley iris syndrome. I think our ophthalmology colleagues understand this and they ask all older men whether they're taking these medicines. 5-alpha reductase inhibitors. I think if we don't counsel our patients, most of our patients will say that these medicines don't work. And the main reason is it really takes a really long time for these medicines to really become effective, 3 to 6 months. And most patients, if it's not working by the end of a month, they'll just say, this is just not worth it. So I think if we just give them the, finasteride or dutasteride and we don't counsel them, they'll just assume this is an ineffective medicine. It is also only effective in large prostates. And I think the main time that we should use these medicines is a combination. So when the patient is on an alpha blocker and they continue to have symptoms, I think adding this does decrease the need for surgery and does decrease urinary retention. But the medicines by themselves don't improve symptoms that much. The IPSS score decreases by about 4 points, about half that of alpha blockers, and the improvement in urine flow is about 10%, again, about half. They have sexual side effects, decreased libido, ejaculatory dysfunction, erectile dysfunction, but also gynecomastia. And, and they do shrink the prostate, and the PSA that decreases by about a half. So instead of using 4 as the upper limit of normal, I think we have to really decrease that to 2. There's a concern because in the studies, there was an increase in Gleason score, but a decrease in prostate diagnosis, and which is concerning because more aggressive prostate cancer is probably much more of a concern than just more prostate cancer. But fortunately, there's been no definite increased risk of death. It's a little bit unclear what to do about that, but it's still a concern. Combination medicine. So the finasteride and doxazosin has been studied. Dutasteride and tamsulosin is actually in a combination pill, so you can use one tablet. Both of these combinations have decreased the need for surgery and urinary retention. Alpha blockers and tadalafil. Adding tadalafil to an alpha blocker, unfortunately, doesn't really improve the IPSS score over and above what the alpha blocker is already doing. It also doesn't significantly increase urinary flow, but it does improve quality of life and erectile function. Alpha blockers and antimuscarinics and beta-3 agonists. Unfortunately, men that have improved urination don't always have an improvement in storage symptoms. And so there was the recommendation of adding antimuscarinics and beta-3 agonists to those men with storage problems. So what we mean by storage is frequency, urgency, nocturia, and urge incontinence. And so these medicines were recommended, but in 2023, there was an amendment to the AUA guidelines on PBH that read, recent evidence highlights an association between the use of anticholinergics and incident dementia. Therefore, it's recommended that benefits and risks of anticholinergics be carefully weighed and discussed with patient and family. I think the evidence is concerning. There does seem to be a multitude of non-randomized case-controlled data that would suggest that higher use of anticholinergics does increase the risk of dementing illness. So I think it is definitely a concern. So what can we do? This is one of the 3 or one of the beta 3 agonists, Vibragon. It is FDA indicated for overactive bladder symptoms, frequency, urgency, and urinary incontinence, mainly urge incontinence, in adult males on pharmacologic therapy for BPH. So this is not indicated as a standalone initial medicine, but it is indicated as an add-on. The benefit of Vibragon versus Mirabrigon is that it does not inhibit the CYP2D6 enzyme, which is important for metabolism of antidepressants, paroxetine, fluoxetine, and tricyclics. Also, pain medicines, codeine and tramadol, and antipsychotic medicines, haloperidol and risperidone. So there's a number of interactions with that. I think the main concern with Mirabrigon is that it is also associated with increased blood pressure, and there's a warning of not using it unless the blood pressure is very well controlled. So this medicine has a similar efficacy to tolterodine, and the blood pressure response was the same as placebo and tolterodine. So it doesn't have the same concern in terms of the blood pressure. And there's a new randomized controlled trial of Vibragon versus placebo. This is a trial in 1,100 men over the age of 45 with overactive bladder symptoms on an alpha blocker with an IPSS score of greater than 8 and nocturia greater than 2. So at 12 weeks, there was a decrease in micturition by about 1, which would probably be clinically significant. Daily urgency, again, about a decrease in about 1. Secondary endpoints, nocturia really a minimal decrease, although it was statistically significant, but an urge incontinence episode of also about 1. So the adverse effects were hypertension, COVID-19, UTI, and hematuria. There was no difference between that and placebo. So the indications, yes.
Question in the chat. Mirabegron, it does inhibit CYP. Is it effective in the same way? And do you use it when able?
Uh, I have not used it clinically that much, mainly because of its expense, but I think I would consider it now.
Question in the chat. With so many patients on testosterone, what are your thoughts on the latest evidence regarding testosterone and BPH?
I think it's one thing we have to counsel our patients because the testosterone will get converted to dihydrotestosterone, and that will, worsen the BPH symptoms. So it's a trade-off between, the symptoms of maybe low testosterone versus BPH, because I think it will definitely make it worse. So indications for surgery, bladder stones, hematuria refractory to medical therapy, high pressure chronic recurrent urinary retention, intolerance to medical therapy, increased post-void residuals, recurrent urinary tract infections, renal failure from hydronephrosis, and urinary symptoms unresponsive to medical therapy. That's probably the main indication. These are the recommended studies prior to surgery recommended by urology. So just go through a couple of these. Urinalysis, cystoscopy is really to assess prostate size and shape, the degree of urinary obstruction, and the condition of the bladder. I think the urologists really do want to take a look at that bladder. The PSA is a determination for prostate cancer, which should be excluded prior to surgery. The post-void residual gives them an idea how well the bladder functions. Amounts greater than 200 are considered pathologic. And uroflowmetry, this gives them an idea how well the bladder functions. So they are looking for a peak flow that's greater than 13 and avoided volume greater than 150. Urodynamics really are not necessary unless there's a significant concern that the bladder is really not working. This is really to try to avoid surgery when they think the bladder will not contract even after you relieve the bladder outlet obstruction. And that's really not a common concern or a common thing. So your patient continues to be bothered by his urinary symptoms and requests surgical evaluation. He's very concerned about maintaining sexual function. What do you recommend? A TURP because that's the gold standard, a prosthetic Euro lift, water vapor therapy, aqua ablation. So given his concern about sexual function, the TURP, even though it is the gold standard, would not be the correct answer. The TURP is associated with about 3/4 to 80% retrograde or anejaculation. Aqua ablation is much better than the TURP in terms of sexual side effects, but it still has some. The prosthetic urolift and water vapor therapy have really very minimal sexual side effects, so that would probably be where we would direct the patient. So this is from the urologist. So there's only two therapies that are, and they break it down in terms of the size of prostate in terms of recommendation. There's two therapies that are size independent, and those are the enucleation of the prostate, either using the holenium or thelenium lasers. Otherwise, if you have a large prostate, your only other option is a simple prostatectomy. For the average and small prostates, you can see there's a variety of recommendations. And in the box to the far left, eligible patients who desire preservation of erectile and ejaculatory function may be offered prosthetic urolift or water vapor thermal therapy, as data indicates that both therapies provide greater likelihood of preservation of sexual function. So TURP, 86% of urologists perform the surgery, accounts for about half of all prostate surgeries. It's indicated for prostates up to 80 grams. It improves symptoms in the vast majority of patients. About 85% of patients will have an improvement. The IPSS score decreases by 15. Remember, 20 is severe, so if you decrease by 15, it would be putting you way down into the normal range. 10.6 cc's in terms of maximum increase in flow. Most problematic side effect is bleeding, but other side effects are anejaculation, 62 to 75%, other series quote 80%. Erectile dysfunction in 14%, bladder neck contracture, urethral stricture, and urinary incontinence. And retreatment is about 5% at 2 years and 7.7% at 60 months. TUR syndrome is concerning, where we have men with very low serum sodiums who look quite ill. This is only seen in monopolar TURPs using hypotonic solution as the irrigation fluid, and it's sort of recommended that we avoid that. So the HOLEP or holenium laser nucleation of the prostate, size independent. So this is one of the surgeries that you can do on small, average, or large prostates. Compared to TURP, there's less bleeding. The laser sort of cauterizes as you're removing the prostate. There's shorter hospital stays, less catheter time. The IPSS score decreases by 12, which is close to the TURP, and the urine flow is increased by 14 cc's, which is actually more than the TURP. It has lower reoperation rates, 3.3 at 2 years and 6.6 at 60 months. But it has similar anejaculation rates compared to the TURP, about 70 to 80%. One of the big problems is only 8% of urologists perform this surgery, and it only accounts for 6% of the cases. So a couple of the newer procedures, the urolift, this is an office procedure. It's non-invasive, no destruction of tissue, only in prostate size 30 to 80, improves IPS at 9.7 and urine flow 3.7 at 2 years. There's no change in sexual function and improved quality of life. In 2015, when it was authorized by the FDA, it was 1.6 of the prostate surgeries, but it's increased to 32%. Unfortunately, it has the highest reoperation rate, 4 to 19% at 24 months. The other minimally invasive surgery is the water vapor therapy. This uses radio frequency to produce steam that is injected into the prostate size of 30 to 80. It improves IPS by 11 at 60 months. So I think it was 11.4 at 3 months, so it's fairly stable. 5.6 cc's per second at 1 year. No sexual side effects. Complications were minor in transit, hematuria in 3%, dysuria in 11, urgency in 4, and Lutz requiring therapy in 3. Retreatment rates were fairly low, 1 to 3.4% at 12 months and 4 to 7.5 at 60 months. So comparable to TERPs in terms of reoperation. Aquablation. So this is robotic assisted direct visualization and guidance using ultrasound. Pulse saline, no heat, so it uses this pulse saline for hydrodesiccation. It's indicated in prostates 30 to 80. Improvement in IPS is minus 15 at 12 months, and increased flow is 10.3. So very equivalent to the TERP. It had actually in this trial, there was a 0.9% required transfusion, but significantly decreased anejaculation compared to the TERP. 36% is actually very low for any for TERP anejaculin rates. The retreatment rates were actually lower than the TERP, 3.1 at 24 months and 4.1 at 60 months. So there's a couple new therapies I just wanted to sort of mention. There's not really good long-term data. Prostatic artery embolization, they're probably equal to the minimally invasive surgical therapies. There's no sexual side effects, but the retreatment rates were 13 to 24% at 2 years, so actually even higher than the UroLift. There's a temporary implantable nitinol device. This is a device that's placed across the prostate. It's left in place for 3 to 5 days, then is removed. It also shows about equal benefits to the other minimally invasive surgical therapies. There's no sexual side effects, and the 10% retreatment rate at 2 years is actually better than what we see with the UroLift. And the benefit is that it doesn't leave any foreign body in the system. But that's a fairly new device. I think we need to see more data. So takeaway points. Evaluation is pretty straightforward. We do this all the time. A good history, prostate exam, UA, creatinine, and I would recommend the IPSS score. Medical therapy, we should understand the difference in the alpha blocker. It does make a difference in terms of side effects. The risks and benefit of 5-alpha reductase inhibitors. I think this is possibly a consideration in terms of add-on, and then consideration of adding a beta-3 agonist for storage symptoms. I think the data for this is fairly new, and I think it's something that I will consider in the future. When to refer? There's lots of different therapies. There are significant differences in the therapies, but I think in order to give our patients a better idea of what to expect, because I'm not always sure that they hear everything that surgeons tell them. And I think that minimally invasive procedures may change the way we manage the condition. Any questions?
It sounds like who you refer them to may determine what procedure they get. Do you have do our urologists here offer all of those? And do you, 'cause it sounds like TERP is still the one that most of the
Yeah, I think if you refer to urology, I think the vast majority of urologists are trained in doing TERPs, and so that they can do those. In terms of training to use, the lasers instead of the TERPs, I think there's a number that then do that. I think the training in terms of doing the laser enucleation instead of the laser sort of vaporization is a little bit more refined, and so there's fewer of them that do that. And then in terms of these new minimally invasive procedures, most urologists don't do all of them, but they usually will do one or the other. Exactly, finding out who, that's a little bit difficult. But I think the other thing is if the urologist you go to doesn't do it, they'll probably be able to refer you to someone who does.
And I see there's another question, but I'm going to cheat. What is mechanically, what do they do with a Eurolift? How does that work?
Okay, yeah, that's a great question. So they put a device into the prostate and they compress the prostate to the side, and then they fire this gun, and it shoots the a suture through the prostate. There's an anchor that goes on the outside, and then there's a stainless steel that goes on the inside, and the suture is smaller than the prostate, so it compresses it. So they do one side and they turn it around, and they push the other side and they fire it again, and they usually put about 4 to 6. Yeah.
I've had quite a bit of success with Dr. Carrie Thurman for whole lips here, for whole lips. So she's one that certainly does them. In the chat, we have a few questions. Does the PVR have any predictive value in what patients may respond to the various treatments? For example, less than 50 mils, less likely to respond to tamsulosin compared to greater than 50 mils.
No, I think the PVR is really basically useful to see whether or not the patient has storage problems after they're on an alpha blocker. I don't think they really help you, choose medicine prior to that.
And then, given how the prostate size seems to determine a lot of options coupled with variability in exam, I see many men getting MRI for volume measurements. Do we need MRI in most patients before referring or choosing medications?
Good question. I think the MRI is actually maybe a little bit better in terms of looking at a prostate when we're really worried about prostate cancer, because I think, the MRI has improved in terms of localizing concerning areas so that the urologist can biopsy those areas. In terms of size, really, an ultrasound is adequate, and so they don't need to really go to the MRI for the size. And then most urologists, prior to doing surgery, will want to do the cystoscopy because they want to evaluate the degree of bladder outlet obstruction. That'll also give them a chance to look at the prostate, and then they really want to take a look at that bladder to see whether or not they think the bladder is going to be able to contract.
Question that I have, and you can tell me I'm wrong on this, but the IPSS. So I can see how that could be very useful, especially for clinical trials when you're comparing one therapy to another, one therapy to placebo. But practically, I don't find myself using it very often. It's more if someone comes in, they've got the classic symptoms, everything else is fitting, and so we start treatment. So clinically in primary care, are there scenarios where you think it's particularly useful?
I think it's mainly useful when the degree of symptoms are fairly significant, and then you have a pretty good baseline of how bad that is. I got to admit I don't always use it before I start therapy, but I think if it was fairly severe, I would. But I, it would be really nice if this was just easily, administered prior. I mean, if the thing was BPH, and then it's kind of like, if you have a diabetic, you get a finger stick glucose or A1C.
If you have a patient that responds, excuse me, to finasteride, do you keep them on forever?
That's a good question. I think if they're on a 5-alpha reductase inhibitor and they're having improved symptoms, yeah, if you stop it, the prostate's going to increase in size and the symptoms are probably going to come back. But you know, uh, you could try. I mean, because if they do come back, you could always place them back on it, and they'll probably shrink again. I don't think there's not good data, like bisphosphonates and a drug holiday. I mean, it'd be nice. I mean, we should have some data on that. They're just not really as effective medicines either, though.
What is I'm just curious. It seems like the need to generate a higher pressure to void um, causes the problems that come with the detrusor. Do you know what the like is there like a bladder Starling curve or something that kicks in? Like what is it about the higher pressure voiding that tends to cause all of the the irritative symptoms?
I think that's a great question, and there doesn't seem to be any way to really know what sort of differentiates, certain men's symptoms from other men, and especially the ones that that have a problem with the bladder not working. Good question. Don't have the answer.
Well, thank you for a wonderful talk here on BPH. I definitely feel more informed about evaluation and the various treatment options. So thank you very much. Next week, Grand Rounds will again be here in this room in person. When for those attending virtually, here in this room is AO1, seventh floor, the boardroom, and we'll have our quarterly business meeting. So thank you everyone for attending today.
Thanks. Oh, no problem.